Welcome to the Faster Podcast by FLO Cycling, the podcast where we talk about anything and everything that makes you faster on your bike. This is episode 26, and today we have Dr. Ryan Mori joining us on the show. Dr. Mori is a urologist who specializes in reconstructive surgery and is an endurance sports enthusiast. During this episode, Dr. Mori discusses men's health topics including saddle selection, healthy testosterone levels, erectile dysfunction, and much more. If you are a male cyclist, this episode is for you. All right, Dr. Mori, welcome to the show. How you doing today?
I'm doing well. Thanks a lot for having me.
All right, well, thanks for coming on. We sent out a request on our Facebook page to find a urologist, and you were very kind to help us out. So thanks for doing that.
Oh, sure.
Yeah. We did an episode on women's health a while ago, and we really wanted to cover men's health as well. And we felt having a urologist on the show would be the best way to address most of the relevant questions that people have. So I think we should just jump straight into the questions. And one of the things that I definitely want to talk about on the show today is our saddles. And when I first got into cycling, I read an article or an ad that said sitting on a bicycle seat could cause erectile dysfunction. And as a young man, that was a big concern for me. So I think I spent more time researching saddles than any other component on my bike. At the time, I settled on an ISM saddle, which is one of the first companies that really focused on cutouts to prevent the perineum pressure. I may have said that wrong, but I think I said it right.
No, that's right.
Okay, perfect. So could you start by just setting the record straight on cycling and erectile dysfunction, and can a bicycle seat cause erectile dysfunction?
Well, that's a great question, and really it's something that I think people have been talking about for a while. It became popular, I think, in the 90s in the media talking about this, and I think that's when a lot of the saddles started changing. I myself ride an ISM saddle with the nose cut out for whatever that's worth. But,
okay.
I don't think we were really engineered as humans to be sitting on a saddle all day. So we kind of reverse engineer our environment back to ourselves, but it's not always perfect. And saddles are a good example of this. So there is definitely an association between cycling, duration of cycling, and numbness of the perineum, which is really the area between the scrotum and the anus, and that flat area.
Yep.
As well as erectile dysfunction. But the important word here is association. There have been a lot of studies about this. Some of them good, some of them not as good, some of them smaller. We've never really had that gold standard trial, which would be cumbersome to do. So a lot of the studies have shown an association between numbness in the genital region, erectile dysfunction, and saddle, but we can't really say in any case that it's causative.
Okay.
There's a lot of details about it that I think are interesting and important. The perineum, what runs through that is the urethra, and a lot of nerves and blood vessels that go to not only the local skin and tissue around there, but also to the penis for erectile function. And, the urethra is definitely in harm's way, sitting there squeezed against a hard saddle and a hard pubic bone. So a lot of the changes that have happened in the saddle, one of them is a noseless saddle or a cutout nose of the saddle. And that's been shown in studies to actually reduce the pressure and reduce some of the restrictions in blood flow that go to the penis. But there's no cure, there's no pure study out there that says that it's causing erectile dysfunction.
Okay. So it may not be directly causing, or we can't prove that it's directly causing it at this point. You mentioned a cutout saddle. Are there any other things that we can do to promote penile health or even urethral health when selecting a saddle? What are some things that we could look at?
Yeah, I think what seems to be true in a lot of the data out there is if when you sit on your saddle you get numbness, and that can be numbness in the butt, it can be numbness in the perineum, in the scrotum, or numbness in the penis, and that's a common thing. I think probably 30 to 50% of men who cycle a lot experience this. what seems to be true is that if men do get this discomfort and this tingling sensation or numbness, those men are more apt to develop some at least temporary erectile dysfunction. Now, that may just mean in a few days after a long ride, even up to a week. There's no evidence that it's long-lasting, but I think that if you're experiencing these numbness issues, then I think maybe you want to consider changing something.
Okay. And I've noticed on certain saddles, you could ride, 5 hours some days and not get any numbness. And then sometimes you seem to just sit on it odd for 20 minutes and then you're like, oh, I've got an issue with numbness. Sometimes that could just be your positioning on the saddle as well, right?
Yeah, it certainly can. And it's been shown that one of the important factors that can lead to more numbness as well as more erectile or sexual issues is the position on the saddle. Now, it's recommended to be in the 90-degree position on a nice wide saddle. Well,
okay.
That's fine and dandy if you're riding on the beach, but for competitive cyclists, that's not really going to work.
Yeah.
The aero position has a little bit of a higher risk, mostly because when you sit on a saddle straight up and down, you're sitting on your sit bones, the ischial tuberosities.
Yep.
When you're leaning forward, you're putting all the pressure on the perineum, and that's probably what's causing the problem is the pressure there. So a wider back portion of the saddle and less pressure on the nose portion, whether that means a cutout nose or, they even have these noseless saddles, which don't really seem to be, they're not the kind of saddles you can really race in, but they're going to take all the pressure off the perineum.
Nice. I will say that last winter, the one that just passed, I went out to Colorado and had a bike fit from Ivan O'Gorman, he's one of the best bike fitters around. And I've tried many saddles over the years, and he had a system that I could swap saddles in about 30 seconds. I could go from one to the next, and he had every saddle you could think of. And I thought I had a really good saddle, but what I learned by working with him was how off I actually was. So if anyone's listening, they're having issues with numbness or discomfort, I would recommend, I think one of the most important parts of the bike fit that I recognized was how important selecting the right saddle is. And it's pretty cool to be able to test them back to back because you can really compare and contrast exactly what you do and don't like. So that helped me a ton. I want to talk a little bit about building up. I think there's this maybe a misconception with athletics. If you do your first 2-hour ride, that may be very taxing, but over a 3-month process, you may be able to ride for 4 hours. So you can build up your muscular system. I don't feel like perineum or urethral structures build up over time. So is this something that people can build into, or should they always be cautious of this from the beginning?
Well, I think it's important to always be cautious of it. There's some data that says that the longer you've been cycling, the less prone you are to these types of things, and that makes sense. Probably because you've had a bike fit and you're in a good position on the saddle. Actually, another interesting thing that I found is that professional cyclists who probably are spending the most time in the saddle and the most time in aero positions, they actually have less of these issues. And it's thought to be that the more intense you're cycling, I find this. If just last night I was sitting on the trainer and even after 45 minutes of an easy ride, I was in a lot more discomfort down there because I felt like I was just sitting all my weight on it. Whereas the more intensely you ride, you're putting all the watts into the cranks and you're really pushing the pedals, and you're probably keeping a little bit of the perineal pressure off the saddle.
Perfect. Okay, let's talk about fertility a little bit with saddles. Is there a way that fertility or a saddle can decrease your fertility?
Yeah, that's a good question. And fertility is a very complex issue. And, there's so many things going into it, hormones, the anatomy. So theoretically, I feel like the saddle could have an impact on your fertility. Now, if it's causing a stricture in the urethra or if it's causing acute trauma, certainly that's going to stop the transmit of sperm out. And that can certainly be an issue. In terms of, and I think we'll get to this a little bit later, a lot of the testosterone and hormone issues that come into fertility, there's not a clear answer there.
Okay. So as far as, so from a saddle perspective, really all you're looking at is something structural that could be damaged, right? It's
That's
not
right.
like, okay, perfect. So now your specialty is reconstructive surgery. Is that correct?
Correct.
Okay. So this topic is actually right up your alley, this next question. So I've heard of friends getting strictures from cycling. So can you start by explaining what a stricture is and then explain how we can prevent it as a cyclist?
Oh, sure. So what a stricture is it's basically a fancy name for scar tissue. So anything that has a lumen in it can narrow down with scar tissue. And the urethra is in the position where it's running right through your perineum. So the penis and the urethral structures aren't just on the outside. They run underneath. So when you're sitting on your perineum, you're actually sitting on both the erection chambers and the urethra. And as I mentioned before, the saddle's a hard place, and right on the other side of this is the bottom part of your pubic bone. So really, you're crushing a delicate tube between two hard things when you sit on this. So there's one thing that's for certain is that cyclists have a higher risk of getting strictures than non-cyclists.
Okay.
And a lot of the cycling-related injuries are actually acute injuries, and that's a little bit of a different thing. If you fall down, we actually call it a straddle or a saddle injury. If you are mountain biking or road biking or jumping over a fence and you hit hard against your spread open legs, your urethra can be damaged acutely in that setting, and acute damage can lead to scar tissue formation, which ultimately leads to narrowing down of the channel to pass your urine through. If you can't pass your urine, it's not great.
Is there a way to cure that or fix that?
There are ways to fix that. In fact, that's what I spent part of my day today doing. There's both simple approaches to it through a scope, stretching or cutting the scar tissue open. But really, if that doesn't work with one attempt, we have reconstructive surgery where we can remove the scarred segment or possibly patch it.
Okay, interesting. It's funny. My friend who's a urologist, we ride together, and I always get a kick out of what you guys do on a daily basis. I say to him, I'm like, what are you doing this afternoon? I'll say, I'm going to answer some emails, and he's like, I'm going to remove a kidney. It just makes me feel what I do is so insignificant, but it's really, really amazing what you guys can do. Are there any other urogenital issues that we should be concerned with when talking about saddles? And if so, what should we do?
Yeah, I think there's a few others. Men can get something called prostatitis, which is a diagnosis where their prostate can get a little bit inflamed. And really, the prostate's sitting right, the urethra runs through it right under the bladder. And really, you're hammering down on that area when you're cycling, especially if you're bouncing a lot. So that's one thing. And that can produce urinary symptoms where you feel an urge to go and you have to go frequently. And you can have some pain down in the pelvis. And I think a second issue that actually goes hand in hand with prostatitis, I'm sure listeners of yours out there are going to be given this diagnosis at some point, or some have in the past. Prostatitis is often misdiagnosed, and really what's going on is that bowl of pelvic floor muscles that all the rectum and the urinary tract run through, they're susceptible to strain and discomfort just like every other muscle grouping. So I think people can understand it when they have a lot of tension in their shoulders and their neck, and then they have headaches, and their whole upper body's miserable. And as soon as they learn that they're relaxed, that they're holding a lot of pressure there, a lot of their symptoms get better. Well, the pelvic floor is no exception. And I think cyclists in general, from being in the saddle, have a lot more strain on their pelvic floor muscles. So a lot of symptoms with maybe changes in urinary stream or the urge to urinate or frequency or some pain down there can all be explained by those types of things.
Interesting. Okay. Is there any way to know if it's prostatitis versus a pelvic floor issue? Let's say you have an urge to urinate or you're urinating frequently. Is there a difference between those or no?
There is prostatitis. Really, what it boils down to is it's an inflammation in the prostate. Now, you can also get a bad infection that's a prostatitis, a bacterial infection, but most cases of it are really just some inflammation in there. And I'll be honest, it used to be that if you walked into the urologist office with symptoms and you were under 40, they told you had prostatitis. If you were over 40, they told you you have an enlarged prostate. And I think more and more we're coming to understand the importance of the pelvic floor muscles. And you know, the angle of tilt of the pelvis when you're in the saddle is not normal. So that can have a lot of implications on those muscles and can produce some symptoms.
Okay. And how do you address the pelvic floor muscle issues? Is it like a physical therapy, or what is it?
There actually is a physical therapist. Now, not all men need to go to that. But there are physical therapists that directly teach you how to interact with those muscles. Really, the pelvic floor muscle is the muscle that allows you to stop and start your urine stream at the urinal. So, you know, next time you feel that, and then relax it to let the urine out. And many times it's those muscles that are getting strained. Interesting.
Okay, let's talk about endurance sports in general and men's health. So, you know the saying, everything is good in moderation. And we talked about the negative effects of fertility when it comes to saddles. But I would also guess that there are some positive effects with exercise. So does the right amount of endurance training, can it improve your fertility?
I certainly think you hit the nail on the head there with moderation. It definitely does. I mean, there's no doubt about it. When we look at fertility and when we look at erectile function, there's actually large studies of men across all ages with erectile function. More sedentary men have worse issues with fertility. They have worse issues with erectile dysfunction. So the more healthy of a lifestyle, the better your fertility and the better your sexual function is going to be.
Okay. And then there's also, on the other side of the spectrum, if we do too much and we're really affecting hormone levels or you're overtrained, I'm guessing that erectile issues, fertility, libido, all of those things are going to lower, right?
Yes.
Okay, perfect. So aside from a situation where someone is maybe overtraining, you're basically saying that endurance sports in general are good for a man's overall health.
Yeah, I think endurance sports are good for a man's health. Definitely overtraining fatigue, definitely overtraining in endurance can lead to lower testosterone and symptoms like that. But
okay, perfect. All right, let's talk about prostate health. Now, prostate cancer rings a bell for us at FLO. Our father had it, and he's a survivor, so that's good. And because of some great doctors and early testing, his life was saved. He had a very aggressive form of cancer that likely would have killed him if he would have went another 6 months without it being detected. And he got it early. I think he was 54 or 55 when he got it. So let's talk about it because it's a serious issue that a lot of guys shy away from. I think the test scares a lot of guys. You know, the exam. Nobody wants to go in and have the exam. So let's talk about that, and let's just start by having you explain what a prostate is and what it does.
Sure, and I'm glad to hear your dad's doing well, of course, and
Thank you.
That's really a testament to PSA screening, which we can talk about.
That's what caught it. Yep.
Yeah. Well, the prostate, it's basically a reproductive gland. It sits in between. It sits just under the bladder, and the urethra actually runs through it. So you pee through the middle of it, like through the core of an apple. And it always makes me think about the movie Fight Club. You know, I'm Jack's colon, I got cancer. The prostate does three things. When you're young and of reproductive age, it makes a portion of the fluid that the sperm swim in. So it makes a lot of the semen that comes out. Outside of that, it enlarges as you get older and causes lots of symptoms, and it gets cancer cells in it. And those are really the three things that it does.
Okay. Now, I've heard that if everyone lived infinitely, that's at some point in a man's life, you will always get prostate cancer. Some people get it early, some people get it later. Is that true?
That's essentially true, and I usually say that your risk of having prostate cancer cells in your prostate is pretty much equal to your age. So if you're 70 or 80 years old and we took the prostates out of every 80-year-old guy in your state, we could probably find cancer cells in 80% of them.
Okay, that's a really good metric. Interesting. Okay, so when it comes to sitting on a saddle, are there any negative effects on prostate health?
Well, there's no link with prostate cancer.
Okay.
There can be, like we talked about, a little bit of inflammation in the prostate, but yeah, nothing with prostate cancer.
Okay, so that answers that. Okay, well let's talk about prostate cancer, since that we know that the prostate health really isn't affected except for some minor inflammation. So, can you just start by explaining what prostate cancer is and what causes it? I think a lot of people have a general idea of this, but your perspective may be a little different.
Sure, it's the most commonly diagnosed soft tissue cancer in men. So,
okay.
And of course you'd expect it to be, because if we could find it in almost everybody, we are going to find it in a lot of men. I think what some people don't understand about it, though, is prostate cancer isn't one lump diagnosis. It's really a spectrum of abnormal mutations in cells that we find. And the only way to find it is on a biopsy of the prostate. But when we find prostate cancer cells in men, they can range in severity to extremely slow growing and unlikely to get out of the prostate and affect your life in the next 15, 20, 30 or more years, to the other end of the spectrum, which is more aggressive cells, which may be more threatening over the next 5 to 10 years. In general, prostate cancer isn't one of those cancers where you find out you have the diagnosis. If it's still confined to the prostate, the immediate risk to your life is generally not going to be high if you get it treated. Not all prostate cancers require treatment, so really we differentiate between an indolent or non-aggressive cancer within the prostate versus one that has a high risk of getting outside of the prostate.
Okay, interesting. Is the disease hereditary? Meaning, if your father had it, are you likely more to get it?
Yeah, that's a really good question. And because it's so prevalent, you'd be hard-pressed to find a man that doesn't have a man in his family who's at least had the diagnosis. But having said that, it is clear that one of the highest risk factors and one of the reasons to even maybe consider screening early is if a first-degree relative, which would be a brother or a father, had aggressive prostate cancer. And aggressive prostate cancer means they were diagnosed at a young age. Young means in their 50s, or had a aggressive enough prostate cancer that they developed metastatic disease, or they had very aggressive cancer at the time of treatment, even if they were cured from it.
Okay. And so I know a little bit about this because my father went through it. So you have Gleason scores, right? Where there's two of those. And then you also have margins. So by margin, I mean if the cancer is contained within the margins or the outside wall of the prostate, that's technically non-invasive. When you say metastatic, that means it's advanced beyond the margins of the prostate and entered other areas of the body?
That's correct. It means you find it either microscopically or visibly on CAT scans outside of the prostate.
Okay. So you mentioned, let's talk about what age men should start getting tested. And you mentioned that guys who have fathers or brothers who've had it at a younger age, maybe they start earlier. What are the age ranges you recommend men getting tested?
Well, urologists, we believe in PSA screening and prostate cancer screening. And really the screening is both the finger exam, a rectal exam, and the PSA blood test. And a few years back, this came under scrutiny because of some sort of miseducation about some data on the long-term benefits of screening. And we really believe strongly in this, and the pendulum is swinging back towards it, certainly with primary care docs. We believe you should start at age 50 to 55 if you have normal risk factors, meaning you're just a man in general. And really, you need to have a conversation about this with your urologist. If you have increased risk factors, such like we talked about, having a father or a brother with more aggressive disease or disease at a younger age, then we may have a conversation about moving that earlier to maybe age 45.
Okay, perfect. That's great information. So you mentioned the finger, the digital rectal exam, and the PSA screen. Are there any other tests that we should have done?
Not for prostate cancer screening. I think that those two, as well as a conversation about some of the risks of being screened in general, are what you need to have done. And it can start with the primary care physician. It doesn't need to be with the urologist.
Okay. How often should we be tested once we start the process?
Well, typically we do it yearly. There are some new ideas about spacing it out in men who are in lower risk, but yearly is what we currently recommend.
Okay. When we do get the blood results back, what are some test results that would indicate a need for further testing?
Well, that's a great question that we could probably spend a few hours on if we had to. But the short answer is there is no such thing as a safe PSA in general. However, having said that, and again, the different categories vary by age. We used to use a cutoff of 4. Oh, your PSA is 3.5. Okay, that's fine. It's 4.5. We better talk about a biopsy. And really, we found that that's just not true. The behavior of the PSA over time is certainly important. So if you're always less than 1 and now all of a sudden you're 3 and it sustains there, we really want to take that seriously. And of course, the higher the number gets, the more we worry.
Okay. All right. So for men who do get diagnosed with prostate cancer, can you discuss some of the modern day treatment methods and why a listener may consider either of those options?
Sure. One of the risks of doing screening and getting a biopsy is that you find out you have a cancer that you never needed to know about. So if you have one tiny sliver of a Gleason 6 prostate cancer and you're 70 years old, almost surely this is not going to affect your life. So one treatment option is what we call active surveillance, where we continue to watch the PSA, redo biopsies, possibly get an MRI, but we don't really do anything unless there's evidence that things are progressing quickly, and we expect that we're still able to cure it with delayed treatment. So that's one treatment option that's not appropriate for men with higher risk prostate cancers. With higher risk prostate cancers, or a man who's younger at the time of diagnosis, really it comes down to either surgery to remove the prostate gland or radiation to it.
Okay. And so my father had the radical prostatectomy where they removed the prostate. Some people put the radioactive seeds inside. Can you discuss the pros and cons of the prostatectomy where you remove the prostate versus the radiation?
Oh, yeah, of course. And they're both meant to be curative, and they both are great treatment options, but they're a little bit different. Surgery, it has a hit up front, and there's always going to be side effects, sexual side effects, urinary tract side effects, some risk of leaking urine afterwards, which can be, a terrible thing for men. And that's part of what I take care of is I do survivorship, and I take care of men who have had their prostates removed. But generally speaking, you take a hit up front and then you slowly recover over time. That's with surgery. Radiation, you have less symptoms at the onset, but the symptoms can build over time. Also have sexual dysfunction and urinary tract symptoms. One thing, we tend to lean younger men, especially men in their 50s, more towards the prostatectomy. They do better with it, and one of the things that's important with the prostatectomy is when you radiate the prostate, the PSA test doesn't go to 0; it goes to some low number, and you follow it, but there's not a clear indication of what's going on as much as there is when you remove it surgically, because the PSA should be not detectable. So any detection of it in the future keys you in very early to a possible problem.
And so my understanding of that is my father's score has been, undetectable for the last, I think, 7 or 8 years. So if there is a PSA detected at a later point, that means that the prostate cancer has basically landed somewhere else in the body and is starting to develop. Is that true?
That's a leading possibility, is that either microscopically or visibly there's some prostate cancer that had been out of the prostate and is now starting to grow, or it could mean that a little bit of normal prostate or a little bit of prostate cancer tissue is left behind in the area and makes a little bit of PSA. But it's an objective value that you can then measure and follow.
Perfect. Okay. So obviously testing is the best way to protect ourselves from anything that could come up, but men can be stubborn creatures and never go to the doctor. So for the guys out there who haven't gone to the doctor and are afraid of being tested or just not doing it, are there any warning signs or symptoms of prostate cancer that they should be looking out for? So if they notice X, it's something that they really should go get checked out.
Yeah, the thing about prostate cancer is it's essentially asymptomatic. So now the prostate's not, and I see, 50, 60 men a week with symptoms from their prostate, and it's because they have what's called benign prostatic enlargement, and that pinches off the urinary stream and gives lots of symptoms. But the cancer doesn't tend to grow around the urethra. It grows in the ridges, the outside rim of the prostate more commonly. It doesn't really produce symptoms. So there's no way of knowing. What gets men in is the symptoms from BPH. And then many times we find prostate cancer with the screening.
Okay, and BPH is
benign prostatic hyperplasia. That's the enlargement of the prostate that all men have to look forward to.
Okay, perfect. All right, let's shift focus to the kidneys and the bladder. That's all part of your world. So when it comes to endurance sports, hydration and electrolyte replenishment are a critical part of that. So can we damage our kidneys if we get too dehydrated or become hyponatremic?
Well, that's a great question. And dehydration and hyponatremia are both important and potentially dangerous. They're a little bit different. Most of my knowledge on this comes because I do endurance sports, less so because from my being a physician, because really nephrologists, which who are much smarter than me, they deal with this. I just take care of the plumbing. But so dehydration, it definitely affects the kidney function. If you're dehydrated and you go get blood work done in your kidneys, the number looks worse. But it's usually a temporary thing unless you're chronically dehydrated. All endurance athletes, if you're sweating, if you're doing it in hot weather, you're losing more fluid than you're taking back in. So by definition, you're dehydrated.
Okay. So you'd have to have a pretty severe case of dehydration to do any permanent damage to the kidney.
Yeah, as long as you then rehydrate after the activity. It's people who have chronic losses from their gastrointestinal tract or don't have access to replenish their fluids or aren't able to do it that become chronically dehydrated. And that can take its toll on the kidneys, the electrolytes, and a lot of metabolic parameters. But generally speaking, for the athlete, dehydration is going to be something that you can then fix within a few hours.
Okay. Now, I use the word hyponatremia, and I probably should have had you explain what it is first. Can you explain what it is and what risks it presents to a human?
Yeah, this is an important topic because when you lose fluid, that's dehydration. Hyponatremia, and basically it just means low sodium in the blood. That happens also in endurance athletes, but really what that is our sweat has salt in it. So you're losing salt and water in sweat, in your respiration when you're at a higher respiratory rate. But we tend to replenish it with water. So we're adding water to an already salt-depleted blood system. And what it does is it dilutes down the sodium. Our bodies are pretty clever at keeping the sodium in the blood at very stable levels. But when we start taking on excess water, and I know a lot of athletes are trained even to drink more than they think they need to, and really thirst is the mechanism we've developed to replenish and to rehydrate ourselves. But taking free water can dilute the sodium even more. And there's also in athletes a hormone that's released to try to keep the blood volume high called antidiuretic hormone or vasopressin. And what that does is prevent the kidneys from getting rid of water. So it retains even more free water. Once the sodium levels in the blood start dropping, that can be dangerous.
Okay. And obviously just replacing with an electrolyte replacement like sodium tabs or something like that. That's how you can prevent that.
Yeah, I think that's important. That's what I do personally. Especially when I'm sweating a lot, I'll take some salt with my with my fluid volume, and really making sure you're only drinking to thirst. So don't just say, "Well, every mile marker, I'm going to down 3 waters because someone's going to hand them to me."
Okay.
and hyponatremia, when we see and we hear about these unfortunate deaths, in training camp or in endurance athletes, usually that's coming secondary to the low sodium, because it can start out with mild symptoms, headache, confusion, cramps, but your brain can actually swell, and it can be difficult to pull out of that. It can be deadly.
So the hyponatremia can cause your brain to swell and then cause death?
Yeah. In this, in very low levels, once you hit critical levels in the blood, it's sort of hard to correct at that point. And these rare deaths that we hear about and we read about, they're probably more related to the hyponatremia than they are dehydration.
Now, there's also the potential for hypernatremia, which is over sodium, right? So if you're taking salt tabs and you take, way too many, what are the risks of that and the signs and symptoms that we could look out for? Yeah,
that can certainly have risks too. And actually, our sodium can go up a little bit just from sweating, because we actually sweat out a dilute. We sweat out a more dilute salt fluid than our blood's actually made out of. So without taking on more water, the sodium can go up, and that can have implications with the heart and lots of other things, essentially. So we have to be careful. You don't want to be taking on more salt than you need. Probably the bottom line is to make sure you're not taking just water alone when you're really sweating a lot, and probably consult with somebody who's an expert in this to help you guide your electrolytes.
Perfect. So if we have any of the signs or symptoms, or we think we're dehydrated, hyponatremic, whatever, what are some things that we could do to make sure we're as safe as we can be as early as possible?
Yeah, I think first of all, drink to thirst. So if you're feeling thirsty, that probably means you need to take on water. And if you're sweating a lot, at least an electrolyte type drink, if not some salt and water together. And I think really, if you're starting to feel the mild symptoms and you feel something isn't right, you probably need to stop what you're doing and get checked out by somebody.
Perfect. All right. This question actually came in from a listener, and they said that during an Ironman, it was 46 degrees Fahrenheit, so rather cold. And they said that many people lost bladder control during that race. So why would people lose bladder control during cold races?
Yeah, that's a great question. The first Ironman I did was 32 degrees at swim start, so I understand. Actually, cold temperatures and running water or submerging the hands in water are all triggers for overactive bladder. And it's complex, all the innervation of the bladder that I won't get into. But if you talk to patients who have overactive bladder, always a trigger for them is the cold temperatures. Always it's running water. Always it's submerging the hands or other parts of their body in the water. So, and by the way, the pelvic floor comes into play here too, because when you're cold and you're squeezing down all those muscles, you're squeezing down your pelvic floor a lot, and that can produce these urinary urgency symptoms.
Interesting. So I know when you get really cold hands, you lose function in your fingers and your thumbs. Can you lose function in your pelvic floor muscles, which would cause you to lose bladder control? Is that part of it?
Well, I'm not sure that you lose function, but I think that you are basically tonically squeezing them, and they're not going to work as well or as normally.
Okay. Interesting. That's very interesting. All right, let's jump into testosterone. And
sure.
This is a big one. So there seems to be a bit of an obsession with men's testosterone and testosterone replacement therapy. I lived in Vegas for years, and man, every corner you turn, there's an ad for it. It's especially popular for aging men. So I think it's important to discuss this topic, because I think a lot of people get bad information, and it can actually have a negative effect on health from what I understand. So let's just start with some general knowledge. And my understanding is that a man's testosterone rises dramatically through puberty, and then it slowly declines with age. So can you confirm that general theory is true, and that it's normal and healthy for our testosterone to decline as we get older?
Yeah, that's absolutely true. It peaks, like you said, and it gets lower every decade in life.
Okay. And I also understand that at any given age, if you were to get a blood test and get your testosterone value, that there is a healthy range. So maybe it's 200 to 700, but as long as you're within that range, that can be considered healthy.
Yeah, that's true also. And not only is there a range across individuals, there's a range within yourself based on a lot of things, and not least of which is just what time of day it is.
Okay. So before we get into the specific questions about testosterone replacement therapy, can you give us your general thoughts on the topic and some of the major misconceptions that might be out there?
Yeah, I mean, this is a really hot topic, inside and outside of urology. And as you probably saw in Vegas, there's people that, hang up their signs and all they do is prescribe testosterone to an aging population. And that's not really my practice. There's a lot of attention being paid to testosterone and replacement therapy. And the truth is that some men really benefit from it and some men really need it. There's a diagnosis. It's called hypogonadism. And it basically means that those blood tests that we check, a man, even in the morning. So testosterone is highest in the morning. It follows circadian rhythms. We should always test it first thing in the morning. So if they have a value of 90 or 100, and they have the symptoms that go along with it, they will benefit greatly from having testosterone replaced. The problem is if you ask any man, whether they're 30, 40, 50, or 60, especially if they're an endurance athlete, hey, do you have as much energy as you did 10 years ago? No. Is your sex drive as good? No. Are you horny all the time? No. Do you feel like you're not quite as strong in the gym? You can elicit those from basically any man alive and then say, oh, well, you benefit from testosterone. And the truth is, that's not true. And many of those symptoms are just symptoms of living, symptoms of aging, symptoms of being an endurance athlete and training a whole lot. And there are men out there who want it for a competitive advantage. They want it because buddies at the gym said that they're on it. And then there's the men on the other side of the spectrum who really need it due to a diagnosis of hypogonadism. And most people are somewhere in between.
Okay. Just real quick, did you possibly get a little further away from your mic?
Oh, yeah. Is that better?
That's much better. Perfect. Okay. So what are some of the health risks associated with testosterone replacement therapy for those who maybe don't need it and have just found the right questions to answer?
Yeah. Well, for young men, for starters, testosterone is effectively birth control. Not that it should be used for that necessarily, but if young men get on testosterone therapy, they need to be counseled that it will produce infertility in them, at least temporarily. And if they use it chronically, it could be chronic. And a lot of men, even a lot of prescribers, don't quite understand that. Secondarily, it raises the blood cell count, which can be helpful in certain circumstances, especially men with low values who have anemia. But that can also produce risks. There can be issues with prostate health, with raising the testosterone levels. And really the big thing out there that's getting media attention is the cardiovascular risk. And there's not an absolute clear answer here, but what it seems to be is that if you have normal testosterone levels and you don't need replacement and you get it, you can be increasing your cardiovascular risks, cardiac events, and strokes. Or on the flip side, if you have very low levels, replacing your testosterone to normal can actually be protective cardiovascular.
Okay. So you mentioned hypogonadism.
Yes.
Who needs the therapy, and what are some of the signs or symptoms of that, and how does it help them?
Well, really, what the men who we should be treating are men who, number one, have complaints with signs and symptoms, and sexual dysfunction, noticeably reduced sexual drive, anemia, poor bone mineral density, rapidly losing sort of muscle mass, fatigue, mood. These are all signs of low testosterone. Of course, fatigue and mood are not specific just to testosterone. So those are the signs and symptoms, and that needs to then be paired with that would trigger the testing, and then the testing needs to show, at least on 2 occasions, an abnormally low value. So that doesn't mean, oh, well, my buddy's 700 and I'm 500. It means that you're well below the bottom of the threshold.
Okay. You just mentioned a point that leads to the next question, actually, and I think this is a common argument amongst endurance athletes. So we mentioned a range earlier, and I'm going to just come up with an example range. I'm going to say that the normal range for a specific age is 200 to 700. So for the guy who tests inside the normal range at 300 and the guy who tests inside the normal range at 650, does the athlete who has a natural testosterone of 650 have an athletic advantage over the one with the lower normal range value?
Yeah, that's a good question, and it's tough to answer because, first of all, with the way testosterone works, a week later they could have the same value, or depending if they weren't drawn. So if we assume they were drawn at the same time of the day, then there may be the person with the higher testosterone may be able to have a little bit of a better performance, but there's no clear evidence for that.
Okay. So does being at the lower end of the normal range justify testosterone replacement therapy?
It really depends on the severity of the associated symptoms.
Okay. So if you're healthy otherwise, but you're just in the low end of normal, that doesn't mean you should be looking for a doctor who's going to prescribe you testosterone.
That's correct.
Perfect. Okay, that was kind of what I thought. So by design, I said earlier that our bodies naturally have a decrease in testosterone as we age. Are we wrong to, and I have this in quotes, play God and alter the course of nature? Could we actually be causing more harm than good by altering what our bodies are naturally wanting to do?
Yeah, I think that hits the nail on the head also, because a lot of these men are being targeted. If you watch television commercials or you look at online ads, a lot of them are targeting over-the-counter agents that may or may not promise to do this. And there's a lot of places you can go, especially in Florida, other places where you can basically just go in and be prescribed testosterone. And I think there's a lot of potential harm there. So really, I think it ought to be reserved for men who truly have the lab findings and the symptoms.
Okay, perfect. And then aside from, the synthetic replacement, what else? I guess the question is, what could be causing some of these lower symptoms aside from a disease, if you will? Yeah. Are there any lifestyle choices that we could be making, like diet, lack of sleep, stress, anything like that could be causing a decrease in testosterone?
Yeah, that's a great question, and it's important that you noted. If we find in an otherwise healthy patient a very low T, we do need to be looking for medical causes. There can be pituitary issues, there can be tumors, there can be more extreme things that we need to look for. But in general, there's lots of things that affect the testosterone. The more fat cells you have in your body, fat converts testosterone to estrogen. The lower your testosterone is, the biggest inhibitor of testosterone is raising other stress hormones in your body, like cortisol. Poor sleep raises cortisol. Poor diet can raise cortisol. Any stress can raise cortisol. The extremes of the body, and more pertinent to the endurance athlete, there's a lot of associated low T issues with endurance athletes, and it's pretty well documented. And I think it's, especially for men, once they get down to a very low body fat composition, usually below 6%, then there can be some real issues, because all the sex hormones are steroids that are made out of fats and made out of cholesterol. So having some fat actually protects against that.
Okay. So as far as naturally doing what we can to increase our testosterone, I guess your suggestions would be a good diet, good sleep, try not to get too low in fat, and don't get overstressed with life.
Yeah, that, and another thing that I think is really pertinent, especially with cyclists, is long, intense periods of endurance training can decrease testosterone for lots of different reasons, but it's been shown pretty well that high interval intensity or high intensity interval training and strength training actually raises testosterone. So, and then the testosterone leads to improved performance when you're doing that. So I think building strength and high intensity intervals into your training is actually going to combat some of the effects of the endurance training. So, especially so if there are endurance athletes that are suffering from fatigue, it's beyond just training fatigue. I think that getting the body fat up a little bit, eating a good, healthy, balanced diet, getting good sleep, may not necessarily mean adding more in, but just being on some people say they need 10 hours and some people say they need 7. If you get on a good sleep cycle and you're going to sleep at the same time, waking up and you're feeling rested, I think all those things are going to lead to natural increases in your testosterone.
Interesting. You mentioned that the high intensity stuff can help, even strength training. I think that's even more true for men over the age of 40. Is that right?
Yeah, certainly.
Okay, perfect. All right, let's jump to erectile dysfunction, and this is a topic for many men that is challenging to discuss, and I think they avoid discussing it at all costs. But I think it's an important one to discuss because I think a lot of men may be out there looking for information on it without really wanting to talk about it. So let's just start with: can you describe what erectile dysfunction is?
Sure, it's extremely common. So large cross-sectional studies have shown that men from their 30s onward have rates that approach 10, 20, 30, 40% as they add decades on. So it's an extremely common thing. It's basically weakening of either the rigidity of the erection or the ability to maintain it in order to have penetration or intercourse. So that's basically that. We see it across all different. Basically, there's lots of different causes of it and associations with it. I think that's probably where we're going next.
Okay, so yeah, the next question is there's obviously a physiological version of it. So like there's a structural issue or a blood flow issue, but there's also, from what I understand, like psychological conditions that can cause this. Can you discuss the difference between those?
Yeah, and this is really important. So it's like a symphony that's being conducted for sexual performance. So it's usually not just one thing. In instances where you have surgery to remove the prostate for cancer, and then you lose your erections after that, and then they slowly come back. That's sort of one insult. But for most men, it's a combination of things. For young men, the most common type is called psychogenic erectile dysfunction, and that's extremely important. It doesn't mean it's in your head, but it means the way our bodies are built is the sympathetic nervous system under periods of stress or anxiety is supposed to shut the erections down. I usually say if you're a caveman out in the woods trying to spread your seed and a bear walks up, you need to go down so you can run over.
Okay.
So we're still wired like that, only it's usually not a bear anymore. It's losing a relationship or having a bad performance and then having anxiety about the next performance. And that can actually be remarkable. I mean, you can have a 20-year-old kid who says they don't get erections for months, although they are when they're sleeping. They're just, as soon as they start thinking about it and worrying about it, it doesn't happen. And that's a natural response of the autonomic nervous system in the body. And the problem with it is if you're trying not to think about it, you're thinking about it more.
So, okay. So we'll talk about the treatments for different types. What is the treatment for the psychological side where if you're thinking about it, it's not going to happen? How do you address that?
Well, that's more common in a young man who doesn't have any other reason to have a problem. And really, you just need to counsel them and they need to get over it slowly and realize that at some point this is not going to be a problem for them.
Okay.
I kind of ignore the fact that that's not what most erectile dysfunction is. The penis is, like I said, and sexual function is like a symphony of nerves and blood supply. And the phrase I often use with patients, and I think it's really important, is that if the eyes are the window to the soul, I think that the penis is the window to the cardiovascular system. So what we do know is that the small blood vessels and the small nerves of the penis are affected first by cardiovascular disease, high blood pressure, smoking, high cholesterol, and all the things that eventually cause cardiovascular disease. Erectile dysfunction can be an early warning sign, and it can be an opportunity to intervene and prevent further future cardiovascular events.
Interesting. I never heard of that, but that's a really good description, that your penis actually can show issues that are showing up in other parts of the body. Interesting. Okay. I read an article the other day about this may be a wrong technical way to say it, but it was porn-induced erectile dysfunction. And the premise of the article stated that porn online gives you more stimulation in the brain than you would typically receive from a sexual encounter. And the premise was that you're so overstimulated from the online or the visual effect that you're getting from the porn, that when you get into a situation where you're, let's say, with a woman or a man and the stimulus is lower, then you can actually have erectile issues because you're used to being overstimulated. Have you heard of that? And is that true?
I've definitely heard of that. And, part of it can be that, and part of it can be just an altered expectation of, part of the sexual experience is arousal, and that comes from the brain down. So if you skip the arousal part because you're expecting one thing and getting something else, then that's the starting engine for all the other things that need to happen with arterial blood supply and the nerve innervation.
Okay. What are the best treatment options for men experiencing ED? And we talked about the psychological one, so let's talk more about the physiological version of this. What are some treatment options that men can use?
Sure. Well, first and foremost, we always talk about healthy lifestyle. So weight loss can help, getting a better diet, cutting out a lot of the bad food choices can lead to a better lifestyle. And of course, that testosterone being low, which is caused by a lot of those things, can have more acute effects on weak erection. So getting all that system balanced is usually the first step, but that's oftentimes the hardest. After that, there's lots of different treatment options depending on the individual characteristic. We, of course, have all the pills out there that everyone knows of and sees the commercials for, and those can be a really useful tool if used safely and appropriately to help men. I always tell men the same thing. These aren't magic beans. You don't pop one in and sit down with a Newsweek and say, hey, there's my erection. They help you get better blood flow that you otherwise would be getting. So you still need stimulation. Psychogenic performance anxiety can still sit heavily against you. And not every time you do it, it's going to work perfectly, just like in real life without the pills. So that's one of our first line agents. There's mechanical devices out there as well. There's something called a vacuum erection device, which can help pull more blood into the penis. And there's constriction bands that can help hold the blood in. Some are better than others. And then we start getting into more invasive treatment options. A lot of times men who have failed more conservative options, they can learn to give themselves shots right into the side of the penis, which tend to work pretty well to bring blood flow in. There's even surgical options where we put a prosthetic in.
And there's a pump that's like a pump that sits in the scrotum, right?
Yes, that's a penile prosthesis. So there's multiple different types, but you can basically fill the erection chambers that would otherwise fill with blood with cylinders that contain saline and pump them up.
And the saline bag is located in the abdomen. I had this discussion on a bike ride with my friend, a urologist, and he explained basically, right? So the saline goes from the abdomen to the chambers that are inserted into the penis, and then you drain it back to the abdomen when you're done, right?
That's correct, yes.
Okay.
And it can be a great option. It's not quite the same as a natural erection, but it can be a great option to get men back in the game. We do that most commonly in men who have had their prostates removed and are suffering the ill effects sexually from that.
Okay. All right. Is there anything that we've missed about men's health and endurance sports and cycling, or just men's health in general, that we should know about?
Well, I think there's one area that I deal with that we skipped, and with especially in terms of endurance cycling, and that is doing self-testicular exams in young men. So testicular cancer isn't common, but it's one of the most common malignancies in young men from their 20s to their late 30s. So once a month, feel the testicles in the shower, and they should be smooth. There's some bumps around them called the epididymis, but of course, with very well-known cyclists, testicular cancer, although very curable, is a tough thing to go through.
Okay. And what do we, if we do have a warning sign or an issue with testicular cancer, what do we feel?
Well, you're usually going to feel an asymmetry or a hard spot, lump or bump on the testis that shouldn't be there. Sometimes that can be confusing because there's some other structures around there. And there's some other signs too, breast enlargement or what we call gynecomastia. But I think self-exams are important, especially in the younger men and men through their 40s and 50s as well. Okay.
I'm drawing a blank on the medical name. It's where the vasculature around the testicle is enlarged. Varicocele.
Yeah.
Can you talk a little bit about that? Are there any risks with that in cycling, or something? Just explain what it is to men and if there's any issues that they should be concerned about.
Sure. It's essentially it's basically dilated veins that serve the testicle, and the veins. The interesting thing about the testicle, which I guess we could have talked about with fertility and cycling, is that one of the ideas behind decreases in fertility is that the testicles hang away from the body for a reason. Women have their ovaries on the inside, men's testicles are on the outside and away from the body because sperm need to be made at a slightly lower temperature than body temperature. That's why the testicles hang down away. So anything that raises that temperature, compressive shorts, being in warm water all the time, and there's lots of things that may do it, can potentially hurt the making of sperm. Varicoceles, the veins that take blood away from the testicle, take warmer blood away. So if those veins dilate because their valves don't work well, then it can change the temperature locally, and that can decrease some of the fertility, although it's not entirely clear it happens. Most men have some dilated veins there. If men get ultrasounds, about 30 to 50% of them are going to say they have a varicocele. It's usually nothing to worry about at all. It usually doesn't cause many symptoms. The exception is if you've been trying to have a kid for a few years and you can't, and you have larger varicoceles, then fixing them may improve your fertility.
Okay, interesting. All right, this one came in from a user. I think a lot of people have always asked this question. I'm sure you get it all the time. Why does asparagus make your pee smell?
Well, that's a good question. The short answer is I'm not sure, but everything that we take in comes out. So if whatever chemicals in asparagus goes through the kidneys and comes out, then that's probably why.
Okay, I'm going to ask this one. It's not on the question list, but
sure.
Sometimes when you're in a crouch position, like on a TT bike, if you have to urinate really badly, when you stand up, it feels like there's a pull or a spasm in your belly button. Do you know what that is?
That's probably a bladder spasm. When the bladder is just a dumb, big muscular bag, I usually tell people that it's not very smart. So whenever it's overstretched, or if the pelvic floor is irritated, or if commonly when a man or woman has a catheter in that rubs against it, the only emotion it can really have is that it has to pee. And especially if you've been holding it for a long time, the bladder can actually distend up pretty close to the belly button. So that may explain what's going on.
Okay. Yeah, I've had that. I used to call it a belly when I was a kid. I was young. It happened a couple times. I'm like, my belly button's not working. Like, it was weird. But anyway, I've had other guys explain that to me. So, okay, the last question that we'll have on the show it's our famous Watt Point question. And the idea is, if the listener takes all of the advice given by the expert on the show, how many watts is that worth to their FTP? So we always use a cyclist with a 300 watt FTP as a basis. So, we talked about a lot of synthetic things that we can do to increase that, but I don't want to get into that. So what I would really like to do is just say, if a cyclist is overtrained, maybe they have a poor diet, they're overweight, they're stressed out, and their testosterone is low as a result of that, how many watts can they add to their FTP, or you could say lose, versus when they're in a healthy, not overtrained, eating well, good, healthy weight state?
Oh, well, that's a good question, but I'd say that if they're going to correct all these things, and especially if they're going to hit the gym for some squats and some high-intensity strength training to raise their testosterone up, you're going to see a pretty good wattage increase. Maybe I'll say 15.
15 watts. Perfect.
Yeah,
okay.
That's obviously a complete guess out of thin air.
Okay. Yeah, that's good. That's good. So where can listeners learn more about you and your practice? Is there any way that we can help you out with this show?
Well, I'm not really promoting anything right now, but if anyone has any questions for me, I'm happy to leave my email or other ways people can get in touch with me.
Yeah, that would be great. Maybe we could put that in the show notes.
Sure.
I can just put a link to that. And then are there any websites or things like that you would recommend for men to have as, something to check out? Maybe prostate health information or testicular exams, anything like a good general advice site for men that you could recommend?
Well, that's a good question. I don't have any off the top of my head, but maybe I'll send you a couple.
Perfect. Okay. Well, I can't thank you enough for coming on the show today. You discussed a lot of really important topics that I think everyone should talk about. Like I said, some of these issues are hard to talk about, but thank you for discussing them with us. And hopefully we can help keep some guys healthy or even maybe save some lives as a result of this. So thank you very much.
Time for one more quick topic?
Absolutely. I'd love to hear it.
It is probably I can almost guarantee that you have a few people who would be listening who will perk up and know exactly what I'm talking about. And it's a very underrepresented thing. Have you ever heard of Peyronie's disease or Peyronie's syndrome?
I haven't, and I would consider myself rather well-versed in medical things. So no, I have not heard of it. So please, tell us about it.
Well, this is the reason why an old mentor of mine, and I often repeat, says that these things should have come with owner's manuals, because what Peyronie's is it's not a disease. It's more like a repetitive use injury. So people in your audience can certainly understand that with all the training and et cetera. What Peyronie's is it's thought to be that as you use the penis and you have good erections that are like steel pipes when you're a young man, they get a little bit more pliable as you get older, and the elastic chambers that hold the blood, as you have intercourse with a slightly pliable erection, can develop scar tissue on them. What the scar tissue can do is the scar tissue isn't elastic, so it can create a significant deformity, which seems to come out of nowhere. So there's lots of men out there, probably 10% of the population of men over 40 have deformities in their penis, ranging anywhere from a mild bend to a severe angulation to 90 degrees plus that's limiting intercourse. And that's called Peyronie's syndrome, Peyronie's disease. And guys out there have it, and they just don't talk about it. And it's really important to get in and talk to a urologist about it, because we can potentially help you with it.
Oh, interesting. I've never heard of that. So thank you for bringing that up. I'm sure.
Of course.
Yeah. Awesome. Cool. Well, again, thank you a ton. This has been a great episode. People are going to love this one. So thanks for coming on, and we'll talk soon.
All right. Great. Thank you.
All right. Take care. Thank you for listening to this episode. Be sure to listen to episode 27 for an interview with Canadian cycling coach Steve Neal to learn about reaching your athletic potential. If you enjoyed the show, please help us by sharing our podcast and by leaving a rating or review. If you want to learn more about our company, FLO Cycling, please visit us online at flowcycling.com. That's F as in Frank, LOCYCLING.com. You can also find us under FLO Cycling on Facebook and Instagram. Until next time, ride safe.